All right, the power went out, so I wasn't able to get to the putting it all together. So we got through the whole lecture and missed it. So I'll just post this as a separate video for you, so you get the full experience. So this is based off of our hypoglycemia lecture, so let's put it all together. We have a 48-year-old man is brought to the ED by emergency medical services after being found confused and diaphoretic in a public park. He is homeless and has a known history of chronic alcohol use disorder. On arrival, his blood glucose is 42. He's giving an intravenous bolus of 50% dextrose, and his mental status briefly improves, but then deteriorates rapidly. He becomes agitated, develops horizontal nystagmus, and begins to have difficulty with coordination and balance. Vital signs are within normal limits, and there's no focal weakness. Lab studies are notable for mild macrocytic anemia and normal electrolytes. Head CT is unremarkable. I want you to think about what is the most likely explanation for this patient's worsening symptoms following dextrose administration, and then why is the patient anemic, right? That's your bonus. So consider it, and then we'll talk about it. All right, so this we've talked about in this lecture. So this is dextrose-induced worsening in alcohol-associated hypoglycemia. So this is Wernicke's encephalopathy. It was precipitated by dextrose. So this was caused because we gave glucose before thiamine, and as I mentioned in the lecture, thiamine is a really important cofactor for a lot of our metabolic pathways. If I give glucose without the thiamine in a patient who's a chronic alcoholic who probably has thiamine deficiency because of poor diet or because alcohol is messing with the absorption and its metabolism, then we're giving glucose. We're giving the substrate without the cofactor. The glucose is not able to move through these metabolic pathways, and then a lot of my neurotoxic metabolites will build up and can lead to this presentation of Wernicke's encephalopathy. It presents with usually confusion, ataxia, and nystagmus. So nystagmus is the movement of the eyes. I'll do a lecture on vertigo at some point, so we'll talk about that more. So we've talked about this. There's your triad. We always give thiamine before glucose in patients with alcohol use disorder or malnutrition. So management will do high dose IV thiamine, 500 milligrams 3 times a day for 2 to 3 days. We'll transition to lower dose as symptoms improve. Delay in treatment may lead to permanent brain damage or death. Right, so Wernicke's encephalopathy can progress to Korsakoff syndrome. Korsakoff syndrome, we'll get anemia with it, and on it can obviously progress to all the way to like brain death. Okay, this patient has likely macrocytic anemia secondary to folate deficiency. That's due to in alcoholics, obviously the poor diet again can play a role with folate deficiency, but alcohol itself can lead to poor folate handling. And when we have a lack of folate, it can lead to a megaloblastic macrocytic anemia. Go watch my anemia lecture, and I kind of talk about the difference between B12 and folate deficiency. Here's the lecture or the resource I used to build this putting it all together case. Again, sorry, the power went out, so I wasn't able to put this all together. So again, we've talked about a lot in this lecture. I think we have covered more than enough for you to be able to confidently approach any kind of hypoglycemia case on step 1, step 2, honestly, even step 3, or in real life, right? So when we're thinking about hypoglycemia, think about my framework. Is it insulin dependent or is it insulin independent? If it's insulin independent, we've got those 9 causes. If it's insulin dependent, we can think about exogenous insulin or we can think about endogenous insulin. All right. Reach out with any questions you've got. I'll keep the lectures coming. So let me know if there's any specific topics you want me to cover. All right.